Good evening. I'm your host, Arlana Shikongo, and welcome to Heartbeat. So, let's talk about sex. Talking about things related to sex is still a taboo in most of society. As a result, there has been a lack of access to necessary information on how to protect oneself from illness, infections, and unwanted pregnancies. Contraceptives are one of these areas of reproductive and sexual health that isn't spoken about enough, despite living in a 21st century which aims to be more sex positive. So joining us tonight, we have medical doctor and health advocate, Dr. Esperance Luvindao, who does work relating to access to contraceptive and other reproductive health facilities. We'll take a look at what the options are, how effective they are, and whether your partner should be part of your contraceptive decisions. Dr. Luvindao, thank you so much for joining us once again. Of course, your work in this area speaks for itself, and we are so excited to have you on the show.
Thank you for having me, Alana. I'm so excited for tonight. It's one of those topics that always gets me going. So let's do this.
Let's do it. And as I said, sex is always a controversial subject. So I'm anticipating a lot of questions and engagement from our audience tonight. But before we even get into all of that, let's just start off with the basics. What exactly is contraception?
Okay, so contraception, just in simple layman terms, means anything that prevents you from conceiving, from falling pregnant. Now, it is important to understand that there are a wide range of contraceptives available, and this should be within the definition of contraceptives itself, because I know that a lot of people, when they have this conversation, they think that contraceptives, it's just the pill and it's just the injection, but there's so many other contraceptive options that are available. We group them. There are over 10 options actually available when you say the word contraception. Withdrawal is one of those, but I know we'll get into the discussion a little bit later. But contraception just means anything, whether it be a barrier method, hormonal method, or whatever the case may be, to prevent you from falling pregnant or conceiving.
And let's get into these different groups. You said there are 10 of them. Now, I think that may come as a surprise to many because we know the basic ones. We know the pill, we know the patch, we know, withdrawal or pull-out method, even though I think some people might not necessarily consider it a form of contraception. But as you said, it is one of them. If you can just talk us through these different groups, what they are, how they work, and how effective they are.
Okay, so we're not going to do everything because of time and because of the detail that also requires. But in summary, when we talk about contraceptives, we can group them into broad groups. Okay, so you can think of your barrier methods. Your barrier methods are things like your condoms, male and female condoms. So barrier literally meaning something that forms a barrier or barricade between one person and the other. That's where your condoms fall in, whether they're latex, non-latex, doesn't matter. And then your female condoms also fall into that category, all right? And when you talk about hormonal methods, which is a different group, now the hormonal method is one of the most common methods of contraception, right? Now in this group, for your oral contraceptive, sometimes you'll hear your doctor refer to it as an OCP. That just means an oral contraceptive pill, right? Or you can have your injections. Some people know these as the 2-month contraception or the 3-month contraception, but it's also important that in understanding basic health, we get the basic names, because if for whatever reason your health passport is lost and you come to me or any other doctor, we do need to know what you were being treated with or whatever the case may be. So it's important to know that the 3-month injection is called Depo-Provera and the 2-month injection is called Neurasterate. All right. Now, these are also hormonal, and it just basically means that they contain either your estrogen and progesterones, right, that basically deliver hormones into your body. Okay, so apart from the pill and the injections, which we know very well, you also get what people also know quite often, known as the implant, right? Now, the implant is that little rod that they put into your upper arm, And this can last for up to 3 years. It contains hormones, typically progesterone. And we will talk a little bit about the hormones later on. And then you also get what we call an IUD. And if you know anything about me, you know that we did do an IUD campaign, and we are still running an IUD campaign. An IUD, what it stands for is intrauterine device. Okay, now this just basically means that it's a little T shape that literally looks like a little T piece that we put into your uterus. So through the vagina, through the cervix, into your uterus, and that sits there. But now there are two types of IUDs. You can get the copper IUD and you can get the hormonal IUD. So I remember when we were marketing the IUD campaign that we started in the Oshikoto region, one of the things that came out was because I mentioned that, you know, the advantage of this contraceptive is that you don't get hormonal side effects. And then somebody said, no, but doesn't the IUD have hormones? And I said, no, not the one we're putting in, because there are different types. So there's the hormonal one that releases hormones into your body, into your bloodstream. And then there's the non-hormonal one, which is the copper one. And copper IUD, pardon me, literally is that. It's a little piece of copper that also looks like a T. And the reason it stops you from falling pregnant is because that copper basically forms an inflammatory reaction that the sperm doesn't like. And that's why you don't get pregnant. And then, so we've spoken about your barrier methods. We've spoken about a few of the hormonal methods, not exhaustive, but a few of them. And then you also get your behavioral methods. So your behavioral methods are things like abstinence, all right, and things like your pull-out, which is an actual recognized form of contraception. However, as I mentioned, these contraceptions, it's obviously important to realize that the efficacy is not the same for all of them.
Absolutely.
Okay, so before making a decision while listening to me, it's important to weigh those options really well. I always tell people, don't do the pull-out method unless you're ready to be a mommy or a daddy, right? Which obviously means that the failure rate is very high. And particularly with the pull-out method, a lot of what people don't understand is that pre-ejaculation may contain sperm. And so even though you did not come inside your partner, they may still conceive because of the fact that, like I mentioned, pre-ejaculation may also still contain some sperm. And then apart from your behavioral methods, we also have what we call, so what happens here is you can either use your calendar method, right, which just basically means that you're tracking on your calendar to say, okay, today's day 1 of my cycle, and I know that I'm supposed to ovulate round about day 14 of my cycle. So 2 days plus 2 days minus roundabout around those days, I shouldn't be having sex because I know that I'm ovulating. Ovulation just means that the egg has been released from your follicle in the ovary, and you have a higher chance of falling pregnant because there's an actual egg that has been released ready for fertilization. And then apart from that, we also have one of the methods that I don't really like very much, and this involves knowing your body very well. Generally, what happens when you are ovulating is that there's an increase in your basal body temperature. So generally, a normal day-to-day person might not be able to pick this up. You'd need a thermometer and whatnot to be able to tell that, okay, your temperature during ovulation rises usually by about 0.5%. So then you would know that, okay, during this time I'm ovulating. But like I said, please remember, some of these methods I wouldn't really advise because the efficacy is not as high. And so your chances of falling pregnant are quite high. And then the last one that I'd like to tackle briefly is your surgical methods. These are known as your definitive contraceptive methods. For men, we know that these are things like your vasectomies, which just involves basically cutting and tying the tubes through which your sperm passes. And then for women, we call it tubule ligation. And this just basically means that the fallopian tubes are then cut and tied. There are different ways that we do these, but I won't get into the detail. And those are generally your group of options. But no, your only contraceptives are not just condoms and the pill. There's so much more.
Absolutely. So before we dive into it, I want us to kind of start from the top and work down. With the pull-out method, for example, I think on a very basic level, that's what most people, well, a lot of people, let me not say most, but a lot of people rely on that. And as you said, the average person wouldn't know too much about, you know, necessarily the length of their ovulation and all of those things, which kind of makes me want us to talk a little bit about the the efficacy of something like, first of all, abstinence, second of all, the pull-out method, and then thirdly, understanding your flow so that you're able to know when you are potentially more at risk of falling pregnant and when you might not be.
Yeah. Okay. So abstinence is 100%, 100% effective. If you are not having sex, you're not going to fall pregnant. Okay. It is absolutely impossible. There are, certain circumstances in history, religious, etc., that prove otherwise. But generally, biologically speaking, if you're not having sex, you're not going to fall pregnant. So generally, in case of children going to school, people that are not able to deal with the consequences that might occur with, if you do fall pregnant, what then happens? We generally tend to advise this method best, abstain. But we know that for a lot of young people, especially when they've already started having sex, it can be a little bit difficult to talk to them about abstinence and tell them, listen, you need to abstain or whatever. Also, because remember, relationships are two-sided. So it's not just convincing the woman to abstain, but now you also need to convince the other partner. And that can cause a little bit of strain on the relationship. But abstinence, 100% efficacy. Right. Now, the other methods generally, look, when you read various literature, some of them will say that, look, your condom is very effective, about 98%. Some will say 99%. And so the numbers tend to differ really by 1 or 2%, depending on what literature you read. But like I mentioned, pull-out is right at the bottom. So I would generally not be considering that as an efficient method, all right? Because one of the things we talk about when we do talk about the pull-out method is that it requires a lot of self-control.
Yes.
And unfortunately, that is a conversation whereby, one partner might say, okay, I would really, really love to, ensure that we do this. But then the other partner in the moment, in the heat of the moment, might, just lose control and things happen and then you fall pregnant. So, but apart from just the control aspect, like I said, it's important to realize that pre-ejaculation may contain sperm, all right? And that is very important because some people think that the only time there's sperm and contact with sperm is when you have actually ejaculated. But there is what we call pre-ejaculation, which is just self-explanatory, but they might contain some sperm in that. And so the efficacy is generally very low. So let's quickly tackle the issue of flow. I like that you asked that because we actually had a Clubhouse talk about menstruation yesterday, and it was so interesting how many questions came from this. And it's interesting to know that there's so many women that don't understand the basics about their cycle. And this is very important because if you don't know the basics, you don't know when it's abnormal. And all these things will affect you, including contraception, because all these things are hormonal related. So when we talk about menstruation, all right, let me just basic straight to the point. Your cycle is generally 28 days plus or minus 7 days. This is your cycle, not your duration of bleeding. So 28 days plus 7 days means 35 days, minus 7 days means 21 days. So meaning your cycle can range anything from 21 days to 35 days, and 28 being the median, and that is generally considered normal, okay? Now, your cycle, your actual bleeding, the actual menstruation, so bleeding out from the vagina, from the uterus into or through the vagina, that lasts 4 days plus or minus 2 days, meaning 4 days plus 2 days is about 6 days, minus 2 days is about 2 days. So 2 to 6 days. You do get some people going to 7 days and some people going to 8 days, okay? So depending on your body, your physiology, these may still be considered normal, all right? With literature and in medicine generally, they teach us that every patient is unique. But if you're having periods that are lasting about 12 days, 15 days, you know that there's a problem and you should be seeking help, okay? And then the other definition that you should understand is to understand, that your period has, or your normal cycle has, generally a certain amount of blood flow. So generally we expect about 40 to 60 mils of blood, right? And some literature goes to say 80 being the maximum. So if you're bleeding more than 80 mils of blood per month, that is then leading to what we call menorrhagia, which means you're bleeding too heavily, too much. And this is obviously then also a sign that something is wrong. But because the conversation is not about menstruation, I think I'll end there.
Absolutely. No, thank you for that. And I think
Yeah.
that helps us get into the other part of this, discussing mostly the contraceptive methods themselves, hormonal
Yeah.
versus non-hormonal, as you said. And, you know, some of the more popular ones, of course, are the pill, the injection. As of late, the implant and the IUD have also become very popular choices for women. So I think let's start off with the pill and go down the list. How does the pill work? Is it a hormonal method? What does it put into your body to help you prevent pregnancy?
Okay. So your pill, I will try and keep it all as layman terms as possible, because I understand that we probably have a wide variety in the audience. And I do want everybody to take at least something from it. If you are in the medical field, you have an advantage because obviously you would understand everything easily. If you are not, I will still try and be as layman as possible, if that even makes sense. So with your pill, okay, what it contains is you can have. Let me first explain this, okay? The two most important hormones when we talk about, there are 4 hormones that are very important when it comes to periods and contraceptives and all of that, all right? That is progesterone, that is estrogen, that is your FSH, which is follicle stimulating hormone, and then that is LH, which is your luteinizing hormone. Now, I know that sounds like big words, so let's leave the last 2 out, FSH and LH, because, hey, I don't think a lot of you are trying to be doctors. You're just trying to get the basics. So estrogen and progesterone are your key hormones, okay? Just like in a man, the main hormone is testosterone. In a woman, the main hormone is your estrogen, right? And then you have your progesterone also. Now, generally speaking, the amount of you, and I'm explaining this so that we understand how the contraceptives work, because it'll answer the question of how the oral contraceptive, the pill works, the injection works, all the hormones, how they work. And I think that'll be easier for us to just sum up. So generally, in a woman's cycle, okay, your cycle is generally divided into 2 groups. Remember, I said your cycle is about 28 days.
Yeah.
So in your first 14 days, right, generally there, the hormone that is persistent or high is your estrogen, all right? And your estrogen has a responsibility to basically cause a thickening of your endometrium, your uterus lining. And simple biology will tell you that in order to get pregnant, right, you need the sperm and the ovum, not just to meet, but they need somewhere to stay. And the place where they stay is that uterus lining that has been thickened by the estrogen. All right. So that's why in your first 14 days, what is happening is that you don't see anything happening. But the reason you're not bleeding is because your lining needs to thicken before you bleed. Right. So when you're bleeding, when that thickening happens, from there, what is then happening is that you get your progesterone spiking, right? So that's the second hormone we said is important. Now, this hormone generally is responsible, okay, layman terms, after the thickening takes place, if you don't fall pregnant, this lining must then break down. This is called your period, right? Your menstruation. Now, the pills contain estrogen and progesterone.
Okay.
So generally what they're trying to do is they're trying to enhance your basic physiological processes. So if you have a lot of estrogen in your body, okay, generally if you're increasing the amount of estrogen in your body, you are increasing the growth of your uterine lining. But if you've had sex, for example, tonight, and you want the morning after pill tomorrow, they're going to give you a progesterone containing pill. Why? Because we said the progesterone helps you with the slopping and the bleeding, right? And the breakdown of that. That's why I give you that pill, because it contains progesterone. And after you take the pill, after a while, you start having abdominal pain, whatnot. After a few days, you start bleeding, because it is basically replicating what normally happens in your body. Okay. So it's not something, the pill and all these things don't contain anything abnormal. It just has what your body already contains, but in high amounts to replicate the physiological process.
Okay.
Right? I hope that sort of makes sense. So what your pill is doing, if you are taking the pill every single day, okay, depending now if it contains estrogen or if it contains estrogen and progesterone. I know we know that there are some pills that just contain estrogen, some that are combined, but that's not too important for today's discussion. I think the most important thing is to understand that your pill can prevent ovulation, which is generally what is happening with your combined pills. Ovulation, remember, is when your egg leaves, right, the ovary, because your eggs don't just sit randomly in your ovary. They sit in little capsules, right? And during ovulation, that capsule breaks and your egg is released. And this happens, like we said, around day 14. And as soon as that ovulation takes place, you can fall pregnant. So if you're taking a pill that is preventing that ovulation, that breaking of the capsule and that release of the egg, then there's no egg to be fertilized. So generally with your combined pill, what you're generally preventing is that ovulation from taking place. Now, the hormones also have other effects, okay? For example, they can help to make your mucus in your vagina more acidic so that the sperm cannot basically survive through it. I don't know if that makes sense. That's layman's terms. So when you're taking this pill, what is happening is that it makes the mucus in your vagina more acidic. And because of that, it makes the environment unfavorable for the sperm. And that's what then happens to prevent you from falling pregnant. So the pills work in various ways, but I just need you to understand the general understanding of what your hormones, what anything that contains hormones does. They can prevent ovulation. They can change the natural environment of the vagina. They can thicken the mucus itself to prevent the sperm from actually gaining access through and finding the ovum and fertilizing. So generally, when you talk about the pill, you talk about the injection, you talk about the implant, all of them generally, depending what hormone they have, work in the same manner to do the same thing.
Okay. I think that's a fairly easy way to understand it. Thank you. That was a really good explanation. So then I think we don't really need to go into the injection and the implant individually because we have an understanding of the hormonal release and how that helps with preventing pregnancy. Now let's move into things that are non-hormonal, like an IUD that's non-hormonal, for example. How exactly does that prevent pregnancy?
Okay, so I wish I had one here, but I don't. I think I have it in my car, but it would be nice to show. Like I said, it has a typical T shape, but it's very tiny. It's definitely not this big, not as big as my hands, please, because when we talk about the IUD, people tend to be really scared and feel like it's such an invasive procedure. Someone needs to put something inside me. How big is it? Is it going to hurt? And all these things. And okay, so I don't know how many centimeters it is, but generally, you know, okay, I don't know if you can really see this, but it's generally like as long as my nail tip there. All right. So it's very tiny. It's T-shaped, and it's a piece of plastic that has copper coiled around it. And the copper, like I said, is basically just responsible for forming that inflammatory. An inflammatory reaction is what happens basically when you have a foreign body or an infection or whatever. So your body is responding in response to that. All right. And by so doing, it then prevents your infection or whatever from becoming too severe. So with that said, your copper IUD is basically replicating that process. Right? Because your sperm, in layman terms, like I said, your sperm doesn't like the copper. And because of the reaction it causes, it then prevents you from getting pregnant. And so that's why one of the contraindications to having the copper IUD is if you're allergic to copper already, then that reaction taking place will obviously not be good for your body. And that's why I always tell people your friend's contraception is not your contraceptive because people have different indications and you must see your GP or your gynecologist to advise you about the best contraception method before undertaking a particular one. So I think that's a very basic understanding of what it does, but it's what we need to know and understand in simple layman terms.
Absolutely. Now, I already see a couple of questions coming in today. We're actually going to take some questions via Zoom. Of course, as we always do, we'll also take questions from the comments on the live broadcast. But at the moment right now, I see somebody trying to join our room. We're just going to organize that so that I can get the information and have them join our discussion and see if they have any questions.
Okay.
All right. So we have Frederica Hamutoko is joining us. Hi, Frederica. Please let me know if you can hear us. Frederica, are you there? All right, I think we're going to try to figure out Frederica's sound, but while we do that, let's just keep going. On the subject of hormones, and you know, some contraceptives being hormonal and then those being non-hormonal, there must be some sort of effect, potential effect to one's body when you're changing the internal environment. So please talk us through a couple of the side effects that come with these various forms of birth control.
So generally with hormones, you know, and this is a conversation that I also had yesterday on Clubhouse, and I was telling them, look, generally I'm not an advocate for hormonal contraceptives because you pump hormones into your body, and you must understand that hormones have side effects. Okay. And unfortunately, if you are not fortunate enough, particularly to be with a GP or a gynecologist that actually takes time to explain these things to you and explain to you your side effects and everything, that would then mean that you would be exposed to certain hormones that might have side effects that may then affect you quite adversely. So when we're talking about hormones, I'm not going to go into too much detail, but I want us to remember basic things, okay? Your hormones are not just responsible, like I said, for your periods and all these things and preventing you from falling pregnant or making you fall pregnant. They also play a very big role in other things. That's why some of the side effects of your hormones can be of your oral contraceptive pills or your hormonal pills are things like weight gain and acne. And your doctor might also ask you, are you a smoker? Okay, your doctor might ask you things like, have you had previous blood clots? Because these things, for example, your pill, for example, your oral contraceptive pill has a tendency to increase your risk of forming those blood clots. So it's important to understand that these things don't just affect you down there, they affect your body as a whole. Right. So even if you're not afraid of the weight gain, or you don't mind the weight gain, you don't mind the acne, it also affects things like your depression. Okay. Now, particularly with people that already have underlying mental conditions, I generally tend to not advocate for things that contain, or pills that particularly contain your combined pills or your combined hormones, pardon me, because of the effects thereof. It does have quite a tendency of causing, like I explained now, because of the effects on your brain and all these things, it can cause depression, it can cause increased anxiety. And so these are all side effects that need to be considered, okay, when deciding to take whatever pill it is. And then obviously then your non-hormonal ones don't contain these things. You won't have the weight gain, you won't have the acne, you won't have the depression, you won't have the increased risk of thrombus formation or migraines or liver toxicity or whatever the case may be.
Absolutely. Thank you for that, doctor. I think we have Frederica with us in the room. Frederica, if you're there, please say hi so that we can see if we hear you.
Yeah.
No, I don't hear anything from Frederica just yet. Let's just give it a minute. Frederica, are you there?
Yeah.
I'm here.
Hi, Frederica. Thank you so much for joining us. How are you?
I'm fine. How are you?
We're doing well. I'm so excited to interact with you. Please go ahead and let us know what's on your mind.
I don't really have much to say. I'm just following Dr. Esperanza. I've been following her on, I've been attending most of her talks on Clubhouse. I've been listening to her a lot. I think even yesterday, or was it last night, she was talking about something on of this nature.
Yeah.
So being a woman, yeah, you get to choose what to listen to, what interests you, and all that. So thank you. Thumbs up for all the good work. Yeah, I'm a mother to a teen myself, so I think myself I have reached pause. I'm 41, so to say, but yeah. My periods are not that troubling. They haven't been troubling, but I know my daughter is 16. She's having sometimes high flow and all that, but we are getting through the profession. So I understand not most, but slightly I understand the background and all that. So keep up the good work. Keep inspiring, keep up like educating, and I'm an educator myself. I work at IUN as a lecturer there for the Faculty of Health. So it's good listening because I'm dealing with young people on a daily basis. Yeah.
Absolutely. Thank you. Thank you so much, Frederica.
Yeah. Thank you.
That's amazing.
Thank you. Thank you.
You're welcome.
All right. For the moment, I don't see anyone else joining us. I'll get to a few of the comments in just a little bit. But before we, go into our audience engagement for the evening, I just want us to have a little bit of a chat on the options available to men. You had mentioned things like vasectomies, for example, and then of course men can also play a role in, taking responsibility for preventing pregnancy through ensuring that they use condoms. Doctor, if you can just talk us through a little bit of those options, that would be very helpful as well.
Okay. So unfortunately, right now, somebody made a comment on, I think it was one of the medical groups I'm in, and they said that, we actually need to focus so much more research in male contraception because if a man wants, he can impregnate 300 women in a year. But a woman generally would be able to fall pregnant once. And if she, for example, gives birth at the beginning of the year, she could then be able to fall pregnant again towards the end of the year. But that frequency is so much less than a man that can get up to 300 or whatever women pregnant in a year.
Yes.
So that obviously goes to show once again, I think I'm not going to speak too much on that, but it does go to show that I think the focus, particularly research-wise, does need to be shifted. There have been quite a lot of people and researchers coming up actually to research and to implement contraceptives for men. And these are hormonal contraceptives, right? There are a lot of them that are still being tested. I know that there was one that was on the verge of being approved, and that is overseas, but then there were a couple of glitches with the international health bodies, and it was then not approved. And because of that, we obviously then still have the issue regarding men being the ones that, can get so many women pregnant and a woman just being able to fall pregnant once or whatever for a certain period of time. So for men, like you mentioned, obviously we have the condom, which is the main barrier method that we all know, right? But apart from that, we also have the surgical methods, like we mentioned, things like your vasectomies, which are unfortunately more permanent. But if a man has reached the stage in his life whereby he feels that he no longer wants to have children, whatever the case may be, that would then be an option to then surgically ensure that that is then ligated or resected or whatever the case is, to ensure that pregnancy or the man impregnating a woman is then not an option. Unfortunately, those are the only options currently available. Like I said, hormonal methods are still being researched, but it is a sign to doctors and researchers that there's a lot of work that needs to be done. And if we can push that along, it would really go a long way. And then obviously there's the simple part of it, which sounds simple, but actually isn't, whereby men need to take responsibility and ensure that, look, if you're going to be sexually active with someone and you feel that you're not ready to be a father, whatever the case is, you do need to have a discussion about contraceptive options. You should agree, and you must obviously ensure that that basic understanding between the two of you is there to ensure that you avoid pregnancy or unwanted pregnancy.
Absolutely. And I'm going to pose a question as well on this specific subject area to our audience.
Yeah.
Do you think, or rather, what are your thoughts on one's partner, specifically men, being part of your contraceptive decisions? Should your partner play a role in the contraception that you choose to use as a method of prevention against pregnancy? So please drop your thoughts in the comments. I'll come back to that. I'd really love to hear what people have to say about that. And while we wait, there's a question here from Loide Hamuniela, who asks, do contraceptives affect your fertility?
Okay, that is an amazing question. Thank you so much for asking that. Okay, so generally, when you go to your doctor and you tell them that you would like to be started on contraceptives, like I said, there is a long list of information that they must give you so that you can make an educated decision. I don't like to push agendas, but I like to be honest as far as possible and as far as my knowledge allows me to be. A conversation that a lot of doctors and specialists don't have with their patients is that if you have been taking particularly hormonal contraceptives for prolonged periods of time, okay, this will affect the time period in which it takes for your body's normal physiology to return back to normal. Because if you've been pumping your body with estrogen and progesterone for the past 15 years, okay, and now you stop taking the pill for 1 month, and then you come to me and you say, Doc, I'm trying to fall pregnant and it's not working. And it's a conversation that we always have to have with patients and try and explain to them. That's why, you know, if people were listening to my Clubhouse talk yesterday, I said this, and I said, hormonal contraceptives are not always my first option for patients. And that's very important for people to understand. It's very important for people to understand that. Because when you have your hormonal contraceptives, what that does to you, remember we spoke about the effects of your contraception, right? Of your contraceptives, pardon me. And because they affect your hormones, and your body, your hormones don't just naturally, just because you feel now that after 20 years of contraception, you now want to have a baby and your body must just oblige. That's not the way it works. You've been pumping your body with whether it be estrogen or progesterone. And because they don't work alone, because your body works with a system of negative feedback for the estrogen and the progesterone. So it starts in your brain, believe it or not. That's what actually controls everything. So there's a part of your brain called the hypothalamus that will release something called GnRH, okay? Fancy word for nothing. It's just a hormone. And that will tell another part of your body to tell your ovaries to release the estrogen and the progesterone. When there is too much estrogen and progesterone, because maybe you've been taking the pill or you've been on the implant or whatever for such a prolonged period of time, what then happens is that, remember, if there's too much of something in your body, negative feedback happens to tell your brain there's too much estrogen, too much progesterone, reduce the GnRH that is being released so that we reduce estrogen and progesterone. And if you then don't have those hormones, your lining cannot thicken so that you can actually implant that fertilized ovum. So it's so much more. I think a lot of doctors don't explain this to their patients, and people will tell you, no, using contraceptives, for long doesn't. Yes, I guess if you've been on a contraceptive that is hormonal for, a month or two or whatever the case is, it might not really affect you, but in a similar manner. But if you have been on these hormonal contraceptives for up to 15, 20, 10 years, you need to understand that you can't just stop taking the pill today and your fertility returns to normal, because the basic physiology of your body doesn't allow that. It's the same as using contraceptives, and then patients will come to me and say, but no, I stopped using the pill 2 months ago, but my period, I haven't seen my period, or my period is irregular, whatever the case is. And we tell them the same thing. You've literally disrupted the normal physiology of your body, technically. And so now you need to let the body get back into the swing of things, if so to speak. So to answer the question, yes, long-term use of hormonal contraceptives will affect your fertility, but you must understand exactly how I explained it. Please don't go and grill me. Understand the manner in which I explained it.
And then thinking about, doctor, actually just hold on one moment. I think we're having a little bit of a technical difficulty. But just thinking about these hormonal changes that happen in your body when you start taking, the various forms of contraception. I know that there are also doctors, or it is a practice that a young woman, for example, will be put on the pill or something of that nature to help with their period. How does that work?
Pain, Okay. So similar story, similar explanation. We have a lot of young patients coming in. So painful periods is what we call dysmenorrhea. Okay. And that sounds like a fancy word, but it's not. It just means painful periods.
Okay.
And a lot of women suffer from dysmenorrhea, particularly because at this point in time, the women are starting their periods much younger. Whereas about 10, 15 years ago, women were only starting at about 16, 17 years of age. Now, I know I had a patient as young as 8 years old starting her periods. So this is obviously complex. The food we eat, the genetics, all these things play a role. We won't get into that. But dysmenorrhea is a very big problem. And my problem always comes in because, like I said, I'm not too much of an advocate of hormones first. I like to exhaust all my other options. My question to that will be, what are you doing to this child's body when you're introducing these hormones to the child? Particularly because of the fact that maybe perhaps they're not sexually active, they haven't even reached an age whereby they've decided on their fertility, whether they want to even have children or whatever the case is. And remember, like I said, long-term use of hormones will affect you whether you like it or not. And because of that, if you're starting like I said, you're starting a 12-year-old on a contraceptive pill, a combined contraceptive pill, or whatever the case is, to help with her period pain, yes, you will achieve your objective directly in terms of period pain, but what are you doing to her body in the long term? And so weighing our options is important. Generally for dysmenorrhea, there's a long list of painkillers that we can try. And any good medical practitioner or gynecologist will tell you that taking Brufen or paracetamol and it doesn't work doesn't mean that you've exhausted your list of options. Based on the severity of the pain, we would then either escalate the medication, or we could say, okay, fine, I'm going to combine Brufen maybe and paracetamol and see how that combination works. If it doesn't work, I can increase to something that's a little bit more potent to help with the pain. But also important to realize when we talk about dysmenorrhea is a lot of women say the pain pills aren't working, the painkillers aren't working. But then I ask them, when do you take the painkillers for your period pain? And they say, on the day of my period. And I say, that's what you're doing wrong. Because remember, your period, you see that you start bleeding on the 25th of August, for example. But the process started a long time ago. And one of the reasons you're having period pain is because of what we call prostaglandins, all right? And if you are having prostaglandins doesn't start miraculously on the day of your period, when the day you start bleeding. It starts before that, right? And there's a buildup. And so ideally, we advise patients to take the painkillers at least 24 to 48 hours before your periods start. And women generally know, either with the calendar or generally because of that premenstrual syndrome, you know that you start bloating and having that discomfort. You know your periods are coming. You should start taking painkillers already if your pain is that severe. Hormones are the last option.
Absolutely. Doctor, we're coming very close to the end of the show, but before we do, we have one question here on access, which I think is something that before we end off the show, we should address. This is from Vicky Chinhua, who says, Oh, actually, apologies, wrong name. This is from Ithete Jade Nelago, who says that at public hospitals, they won't give you the IUD just like that. You have to know someone. So the question here is, I think, where can people go if they need access to an IUD? What is the process actually to be able to get an IUD?
Okay. So in as much as, I like to be very neutral. And as a health advocate, I like to advocate for the people and try and understand what their issues are before dismissing anybody. And unfortunately, access to IUDs has not been the easiest thing. So this person that did comment is not wrong. And I'm not going to comment on the knowing people part, but I will comment on the accessibility. Okay, I know that particularly when we started the IUD campaign in the Oshikoto region in the north of Namibia, people kept coming into my DMs and saying, but I'm in Windhoek and I went to this clinic or this hospital and they said they don't have any in stock, which is a constant problem. Okay, accessibility has a lot to do with, do we even have these things in stock? So one of the things that we've been advocating for is obviously increased procurement of these things because of the fact that we're educating more women. You can't educate 1,000 women on the IUD contraception and then tell 900 of them, well, the IUDs are done.
Yeah.
That doesn't make sense. So if you're going to advocate for people like me and other health advocates, it obviously then challenges us that we obviously now need to advocate and speak to the people within, that make the policies and that sit in the procurement offices and all these things to ensure that we have increased amount as we have increased education. So unfortunately, yes, you are right. Access is not at the level where it should be. We are working on that. I know currently, like I said, I do believe that we still have in stock, and where I was working at the Onanjokwe Hospital, we do have them in stock, and you can go there. You can go to the Shanamtango clinic or area in Onanjokwe Hospital, and you can tell them that you would like an IUD inserted. And we have tried to make the process as smooth as possible. Before, when I was there about a month ago, particularly, we had patients, we had gotten the process so smooth that literally a patient can, if it's regarding an IUD insertion, patient skips the line and the nurse brings the patient straight to me. They tell me the patient wants an IUD. I counsel them within about 10, 15 minutes. I write their name in a book and I give them a date and they don't have to wait the whole day. Unfortunately, we have not managed to smoothen out that process in all health settings, which is obviously a responsibility for us health advocates and doctors and everything to make sure that process is a little bit smoother. It is something that I will look into, particularly here in Windhoek, because there has been a great concern that, in private, it's very expensive.
Yeah.
And then in state, the accessibility is a problem. So it is something that we are working on. I appreciate the question and we will do better.
Absolutely. Dr. Luvindao, thank you so much for joining us this evening. Unfortunately, we are out of time and we are at the end of the show. But this discussion was so titillating, and I will parse through the comments just to see what people had to say and what their thoughts were. What it comes down to is that we need to talk about sex more, because sex is more than just the act of sex. It's about protecting yourself. It's about your body, and it's about knowing what is accessible to you. Unfortunately, that's the end of our show tonight. I had a really good time with our guests tonight, and I hope you did too. This is it from us in the studio. I'm your host, Arlana Shikongo. Good night.